I think respiratory compromise is one of the most dangerous situations for a patient because we sometimes call it the silent way to die on a normal ward in a hospital. Respiratory compromise means that the patient is not able to ventilate adequately or get enough oxygen into the blood, leading to severe cardiovascular complications, ultimately ending at cardiac arrest. It's relatively often overseen, probably underrated, but within the upcoming years there's more and more evidence that these respiratory compromise will really be a danger for our patients.
So respiratory compromise in itself happens all the time on the general care floor. We feel that a general care floor is a low acuity environment that really houses our more stable patients. But the honest truth is that there is a lack of adequate monitoring on the general care floor based on current monitoring protocols. We're monitoring patients in snapshots of time, and we're missing large chunks of time where hypoxemia, hypoventilation, and even hypotension occur. And there is data to substantiate that. And these events or episodes then can translate into true clinical events leading to cardiorespiratory compromise.
So there's been a variety of changes over the last 20 years in perioperative management of patients. There's been increased emphasis on pain control, which has resulted in an increased number of sedating analgesic medications used, such as opioids. In addition, patients today are much sicker than they were 20, 30 years ago, in that patients are heavier, they have higher incidence of obstructive sleep apnea and other sleep-related breathing disorders, and they have a higher comorbidity burden going for surgery today than in the past. So this means that patients today are more sedated after surgery and they're sicker, and this is a setup for having respiratory compromise after surgery.
In Singapore, respiratory compromise is definitely a big concern for post-surgical patients, particularly as we have an aging population and who are undergoing more and more complex surgery. What we find is that the patients who require a hospitalization to stay in hospital after surgery has become much older and much sicker with a greater disease burden. And I think these are the patients, as the Prodigy study will show, are the patients at greatest risk for respiratory compromise.
When patients go to the floor, they're essentially on their own. And that's why the cardiorespiratory compromise on the general care floor is really important, because we've been missing this. We've been missing these events just for the lack of not having enough monitoring or not having the frequency of monitoring that's desired. And that means that we believe that patients are in a safe environment, where I actually feel they're not. We are just making ourselves happy by walking into a patient's room every 4 hours or so and getting a good set of vital signs and believing everything is okay. Where we now know that a lot of cardiorespiratory compromise that is unseen happens all the time on the general care floor. And that's why there is a need to look at this issue in greater detail. A lot of it is based on clinical intuition, and we get it wrong all the time. And that's why we miss a lot of these events. A lot of disasters still happen on the floor on patients who look absolutely normal otherwise. We're kind of oblivious to a lot of damage, and we don't really have a clear set of guidelines to help us define currently who is a patient likely to get respiratory compromise.